Good afternoon, everyone, and welcome to Medical Grand Rounds. Before we get started, just a reminder to please answer a brief survey that will be sent to you right after the presentation, and this will let us know that you were present at today's rounds. And as well, we ask that you please enter your questions in the chat at the end of the presentation. So it's a great honor to have with us today Dr. Arielle Mendel. She is an assistant professor in the Division of Rheumatology at the MUHC and a clinical investigator at the RI here at the MUHC. Dr. Mendel completed her internal medicine residency at the University of Toronto and rheumatology training here at McGill. She then completed a 2-year fellowship in vasculitis and a master's degree in quality improvement and patient safety at the University of Toronto. Her research program at McGill is dedicated to evaluating and improving medication safety in patients with systemic rheumatic diseases such as vasculitis. So thank you very much, Arielle, for being here today. The floor is yours.
Great. Can you all hear me?
Yes, we can.
Okay, fantastic. So thank you so much to the Department of Medicine for inviting me to speak on this topic. And I don't have any disclosures. So this talk is going to be in 2 parts today. The first part is going to have the objective of reviewing the treatment algorithms that we have today for severe GPA and MPA. And then the second half will be to look at a little bit more of the gray areas and reviewing evidence regarding the following treatment considerations in GPA and MPA. Those being steroid tapering, steroid pulses, plasma exchange, and antibiotic prophylaxis. Each of these 4 things may influence the risk of serious infections. And so that's why I think it's an important thing to talk about. So we'll start with a case. So this is a case of a 60-year-old woman who came to the emergency department with significant anemia and difficulty breathing. She had a low oxygen saturation, and on her x-ray, she was found to have bilateral patchy opacities. She did have a couple of episodes of hemoptysis, and so based on this, she was felt to possibly have pulmonary hemorrhage. And her serum creatinine was very elevated at 1,000. It was previously in the low 100s a month previously. And on her urine dip, she had lots of RBCs and some proteinuria as well. So this is what we would call a pulmonary renal syndrome. And when we look at the different causes of pulmonary renal syndrome, if you were a betting person, you should always say that it's going to be an ANCA-associated vasculitis, because when you take all comers coming in with this presentation, the vast majority of the time it will be an ANCA-associated vasculitis. Anti-GBM or Goodpasture syndrome is extremely rare, but it's important to check because the treatment is distinct. And about a quarter of patients with pulmonary renal syndrome will have other conditions, such as lupus or other systemic autoimmune rheumatic diseases. So if we go back to our case, this patient went on to have a kidney biopsy, and she had the hallmark findings of ANCA-associated vasculitis on her biopsy. She had a POSI immune necrotizing crescentic glomerulonephritis. And this is a representative picture here of what her kidney biopsy might look like if it was prepared nicely for a textbook. And the N there stands for necrosis of the capillaries in the glomerulus. It doesn't mean N for normal. And she was found to have an MPO ANCA that was strongly positive, and her anti-GBM was negative. So this is the first polling question. I'd just like the audience to tell me, not everybody may treat one of these conditions in their regular practice, but if if you had this patient in front of you, I guess I'm asking you to tell me what you think the patient ought to get for treatment, initial treatment. So you have the choices of glucocorticoids, which I abbreviated as GC plus cyclophosphamide, glucocorticoids plus rituximab, glucocorticoids plus cyclophosphamide and rituximab, and steroid, cyclophosphamide, and plasma exchange. Okay, it looks like someone has stopped the poll, so I guess you have to be pretty snappy with answering the questions, but I'll just click to share the results. So it's sort of divided between steroids and cyclophosphamide and steroids and rituximab. Very few people selected plasma exchange, and some people did suggest a combination of cyclophosphamide and rituximab. And so we can take away the poll now, and I'll just move on to the next slide. So in reality, there was no right answer in those four questions. It was just 4 options. It was just to give me an idea of what the audience thinks. So, and I'll talk more about that as I go along. So ANCA-associated vasculitis is a systemic necrotizing small vessel vasculitis, and it's pretty rare, between 5 and 15 new cases per million per year, so maybe about 80 new cases per year in Quebec, but we don't know that for sure. The best epidemiologic data from Canada is from a study from Saskatchewan in 2013, where they have one center that collects all the renal biopsies. And so that's how they were able to extrapolate and estimate the incidence, the annual incidence, and the prevalence of ANCA-associated vasculitis in Saskatchewan. They actually found an incidence pretty close to what is found elsewhere in the world. But interestingly, they did find that the incidence was much higher in rural areas at 16 new cases per million per year compared to urban areas. And so this highlights one of the hypotheses that there's something in the environment or possibly genetic triggers or other acquired things like infections or aging that sort of trigger an immune response that causes ANCA vasculitis to start. And the key innate immune cell in GPA and MPA is actually the neutrophil. In eGPA, which I won't be speaking about today, it's more the eosinophil. In ANCA, in GPA and MPA, you have this neutrophil, and inside the neutrophil are these MPO myeloperoxidase or PR3 proteinase 3 antigens that are hiding out inside. And they also are expressed on the surface of the neutrophil. And some genetic or acquired factor, we don't entirely know what, or multiple factors, leads to loss of tolerance, peripheral and central tolerance to PR3 and MPO antigens, which leads to the production of PR3 ANCA and MPO ANCA. And we know that you can have ANCAs floating around without actually having ANCA vasculitis. And so there's something next that has to happen in order to trigger the vasculitis. Currently, the working theory is that something triggers the ANCAs to bind to the antigens on the surface of the neutrophil, and that combined with neutrophil activation from the alternative complement pathway, C5a binding to the C5a receptor, for example, causes the neutrophils to become activated and go to the endothelium and cause damage to the endothelium. And while it's doing that, they also undergo netosis, for example, and this leads to the deposition of these ANCA antigens actually into the tissues, which can then be recognized by the adaptive immune system and cause more tissue injury and also long-lasting immunological memory, which is what we think causes the relapses in this condition and why it's a chronic disease that isn't ever cured. And so what we still don't know, there's a lot of things we still don't know, but why are some vascular beds more prone to this inflammation attack compared to others? Why are there phenotypic differences, but also similarities between PR3 ANCA and MPO ANCA? And so this is still under investigation. In terms of treatment, just like for all of rheumatology, the motto is that if there's a fire in the kitchen, you don't wait till it spreads to the bedroom or the living room. And so the initial goal in the treatment of ANCA-associated vasculitis is to put out the fire. So we classify treatment phases in in GPA and MPA to induction and maintenance. And in severe GPA and MPA, the induction phase lasts between 3 to 6 months, followed by the maintenance phase, which increasingly is becoming longer and sometimes indefinite, although we don't entirely know if that's the right answer. And a mainstay of ANCA vasculitis treatment is still steroids, which are tapered over time. And the decision of how long to continue low-dose steroids and how long that should be continued is still unknown. There's 2 ongoing randomized trials investigating this question. And cyclophosphamide, either IV or oral, is one possibility for induction in severe ANCA-associated vasculitis. And it was Dr. Anthony Fauci, actually in the late 1970s, that published this first series of 22 patients who were treated with cyclophosphamide for a group of systemic necrotizing vasculitides. This is back when PAN wasn't really distinguishable from ANCA vasculitis because they hadn't discovered ANCA yet. And 14 patients out of 22 survived, and that was considered to be very good. And so since then, this has been the mainstay of treatment for severe AAV. There's been several trials since then examining exactly how long and what type of cyclophosphamide to give. One of the more famous trials is the Cyclops trial, where they compared oral cyclophosphamide to IV cyclophosphamide. And it turns out that the efficacy for inducing remission is actually about the same. Although when you look at long-term, there's a little bit more relapse risk in patients who received IV. Remember, this is back in the day where we didn't use rituximab for maintenance. And also, but alternatively, you get more cumulative cyclophosphamide if you give it orally. And there's also probably a little bit more treatment toxicity, both in the short term and the long term, but that hasn't been proven yet for this in this particular trial. The other option for induction is rituximab. And it was in 2010 that these 2 trials were published at the same time in the New England. One of them was from the American group, the RAVE trial, and the other one was from Europe, which was the rituximab trial. And these trials basically confirmed that cyclophosphamide and rituximab were highly comparable in efficacy for induction of severe ANCA-associated vasculitis. And in the European trial, they actually did give people in the rituximab arm 2 small doses of IV cyclophosphamide. So it's actually was rituximab in combination with a bit of cyclophosphamide compared to cyclophosphamide alone. The Europeans used IV cyclophosphamide and the Americans used oral cyclophosphamide in the RAVE trial. And so since then, and by the way, the rate of adverse events was also similar between both groups in the short term, although you can infer that cyclophosphamide will have a higher risk, of course, of fertility in the long term. And now we have this new drug, avacopan, which has been approved by the FDA in the States, but is not approved by Health Canada nor available in Canada. This is based on data from the Advocate trial, which was published in the New England in 2021. And it's a trial of this oral C5a receptor inhibitor that's taken twice a day. And this trial showed that this drug could be used for induction and potentially completely replace steroids altogether, resulting in lower steroid toxicity. And I'll talk about that later. Then we move on to the maintenance phase. So you've completed your 3 months to 6 months of induction, and now you need to maintain remission. What I tell my patients is that, you know, the fire's out, but we have to keep it from coming back. And so we start usually another drug. And 3 months is really arbitrary, but it's technically the point after which you can start to consider someone to be in remission if they have no signs or symptoms of active vasculitis in any organ system. So there's 4 conventional immunosuppressants that can be used for maintenance, with azathioprine and methotrexate being the preferred ones. And this is based on a comparative study, a randomized control trial, where they were found to have similar efficacy for maintenance, both in the short term and in a long-term follow-up study. Of course, methotrexate can't be used in patients with renal insufficiency. There was another trial comparing methotrexate to leflunomide, and they were actually found to be quite similar, or perhaps leflunomide was even better for maintaining remission, but they used a higher dose of leflunomide in this trial than we normally do. And because of a slightly higher treatment toxicity profile, it's still considered kind of a second line maintenance agent. And mycophenolate mofetil was compared to azathioprine in another trial called IMPROVE, and mycophenolate was found to be inferior for the prevention of relapses compared to azathioprine. So this is all interesting and historical, but really the first line treatment these days for maintenance of severe AAV is rituximab in most cases. And this is because this is based on the main RITSAN trial, which is already 8 years old now, and another trial which hasn't been published yet, although it's available in abstract form, called ritaziram. And both of these studies showed that rituximab is superior to azathioprine for maintenance in ANCA-associated vasculitis. So here we have the building blocks for successful treatment of ANCA-associated vasculitis. We don't know yet the optimal length of maintenance treatment, but several studies, either looking at traditional DMARDs or rituximab, both suggest that continuing for 4 years is better than 2 years, and you might extrapolate that continuing for even longer than 4 years might be better as well. But we don't really know how long, and I usually consider patient preference to be the main driver after 4 years. And you can see that over time in Canada, the use of rituximab for the treatment of ANCA-associated vasculitis has increased substantially. So we looked at data from the rituximab patient support program from the time that the RAVE trial was published in 2010 until 2020, when biosimilars of rituximab have become available. And you can see in the black line that the new starts of rituximab for this indication is steadily increasing over time in Canada. And you can see the lighter gray line on the top is the number of new applications completed in order to either apply or renew rituximab. So of course, over time, we can see that the number of applications increases exponentially because you have to keep renewing it for the government or for patients' private insurance. And so this just gives you the idea of how much paperwork, how much our paperwork is increasing exponentially over the years. We also found that public funding for rituximab for GPA and MPA varies widely across provinces. It actually is one of the cheaper biologics that we have in rheumatology, with a maintenance dose only costing about $5,000. And now with the biosimilars, the cost is expected to be about 30% less. So this is all fine, but we still have a problem, which is that the literature consistently shows that we cause infections with our treatments in 20 to 30% of patients with severe AAV, usually at the beginning of treatment, but not always. And the occurrence of serious infections is a predictor of death, so that's not good. And so the next question is, what considerations do we have to enhance the safety of ANCA vasculitis treatment? And so the second part of the talk, part of the objectives, is to review the evidence regarding the following treatment considerations in ANCA-associated vasculitis: steroid tapering, glucocorticoid pulses, why plasma exchange is out or is it, and antibiotic prophylaxis. So time for the next audience poll. What treatment do you start in a hospitalized patient with new severe ANCA-associated vasculitis? Does everybody get what we call pulse steroids, which is when you give 1 gram IV for maybe 3 days? Do you only give pulse steroids to people who are very sick, for example, those in the intensive care unit? Do you not routinely give pulse steroids? Or does it depend on what the other service thinks, that being rheumatology, nephrology, internal medicine, respirology, dermatology, neurology, because this is really a multi-specialty condition. We have a patient on the ward right now, and I think at least 5 services are probably involved in their care. Okay, so hold on. How do I don't know if everyone can see the poll right now. I don't have the option of sharing it, so I'm assuming that people can see it. 73% of people give pulse steroids to everyone, and about 10%, 6 to 10% in the other categories. So we can get rid of that poll and then move on. Okay. So pulse steroids started being used actually initially with kidney disease for rapidly progressive glomerulonephritis. And this is the first report I could find of pulse steroids being used for probably what was ANCA-associated vasculitis. They call it polyarteritis nodosa, but again, at this time in the 1970s, they weren't able to distinguish PAN from ANCA vasculitis. And you can see that this patient had lung granulomata and crescentic glomerulonephritis. So those are 2 things that don't happen with PAN. So probably they were describing patients with ANCA-associated vasculitis, and they saw a very rapid improvement in their outcome with these pulse steroids. And since then, it has really become part of a variety of treatment algorithms, despite that there's actually no RCTs that really support its use in ANCA-associated vasculitis. All RCTs so far in ANCA-associated vasculitis that are induction based have either required methylprednisolone pulses, and usually there's a range that you can give as part of the protocol, or they permit pulses in the protocol, or they still include people even if they've received pulses prior to being enrolled. So it's really something that's hard to study because you have to recruit people right at the beginning before someone has given the pulse steroids, and that's hard. But there's some retrospective data. This was a study from Europe of 114 patients with newly diagnosed GPA or MPA who had a creatinine of greater than 500 or were on dialysis at the time they were started on treatment. And these patients were all treated with cyclophosphamide, and some of them received plasma exchange as well. They did adjust for confounders and other effect modifiers and found that there was no difference in renal recovery, overall survival, or relapses in patients who received pulse steroids versus patients who didn't. But there were more serious infections at 3 months and more diabetes in patients who'd received pulse steroids. And they did find that this was dose-dependent risk. So if you got even a little bit of pulse steroids, your risk for diabetes and infection was higher than if you hadn't received any. So there's also a second similar retrospective study. This one's from China, so it included mostly MPO ANCA patients. They were also dialysis dependent at diagnosis, and they also didn't find any difference in kidney recovery or overall survival. No difference, but they didn't find any difference in serious infections, and probably there was potentially a difference in diabetes between the 2 groups, but it wasn't significant. And other studies that have also been published recently have focused on just general risk factors for infection in AAV, not necessarily on treatment efficacy. And they found that pulses were significantly associated with opportunistic infections and severe infections after adjusting for other factors. So there's a lot of limitations to this retrospective data because there's a lot of bias that can be introduced when you're only looking at the people that survived long enough to be entered into the cohort, for example. But the bottom line is that we still don't know whether pulse steroids are efficacious. And there is a theoretical and probably a real risk for increasing the risk of serious infections and glucocorticoid toxicity. And probably the best way to assess this would be an RCT, but would be very challenging to conduct probably. So this is the next polling question. So this is the same patient who was admitted to hospital with the pulmonary renal syndrome. She has MPO, ANCA antibodies. She was started on induction therapy in hospital. I'm not going to say which induction therapy. I'm also not going to say whether she received pulses or not. But 2 weeks later, she's out of the ICU. She's still on dialysis, and she's on 60 milligrams of prednisone per day. What prednisone prescription do you give the patient on discharge? So do you drop it down immediately to half for 2 weeks and then continue reducing thereafter every 2 weeks? Do you taper by 10 milligrams every 2 weeks until you're on a lower dose and then perhaps taper more slowly? Would you continue? Now, I'm sure 60 milligrams isn't really a milligram per kilogram, but would you continue this dose of 60 milligrams until she was seen as an outpatient? Or not sure is the final option. So I'll end the poll and share results. So interestingly, the majority of people wanted to continue steroids until the patient was seen as an outpatient, and I would strongly discourage this practice. We've had many patients who come to follow up to see us who haven't been tapered on their steroids, and sometimes for whatever reason they can't come to follow up or things get delayed, and before you know it, they've been left on a milligram per kilogram for 3 months and have developed all sorts of complications. So I try to make sure that the rheumatology service gives someone a tapering plan even before they leave hospital, one that will still be safe so that they won't flare up before they're seen in follow-up, but one that will avoid excessive steroids or delayed tapering. And if ever you don't see that the rheumatology service is doing that, you should call them and ask them to give some suggestions. So we'll go to the next slide. So you might be familiar with the PEXIVAS trial, which is since this trial has been published, there have been presentations to the group on this trial, but it is a pretty rare disease, so it's possible that people haven't heard of it. This is a trial that randomized patients to receive either a standard steroid taper or a reduced steroid taper. And it was a factorial design trial where simultaneously they randomized people to receive plasma exchange or no plasma exchange. And in the end, they found that there was no statistical interaction between the steroid dose that was given and the plasma exchange. So they were able to analyze these two exposures completely independently of each other, as if you had done two separate trials. And another trial that kind of asked the same question in a slightly different patient population is something called LOVAS, which was published this past year, which was a study from Japan of patients that were induced with rituximab. They had slightly less severe ANCA vasculitis compared to the patients included in PEXIVAS, and they also compared a high dose to a low dose steroid tapering as well. There was no factorial design with that trial. So this slide is actually courtesy of Dr. Walsh, but I asked him if I could show it because I think it very beautifully illustrates the different trials we have recently in ANCA vasculitis and how steroids were tapered. You can see that the RAVE trial, which is in red, which was one of the original trials from 2010 that used rituximab, actually kind of falls in between eventually the two arms of PEXIVAS, standard being in green and reduced being in blue. And I'm sorry for people that are colorblind. But you can see that, at the 12-week mark, the RAVE taper actually kind of falls in between what would be considered what the two arms of PEXIVAS were. And LOVAS, which is the newest study, isn't pictured here, but you can picture it even having a further reduced steroids from the PEXIVAS reduced arm, such that patients were only on 15 milligrams of prednisone at the 4-week mark. And there's some differences to note about these two studies. Pexivast was much bigger, and in fact, it's the biggest RCT ever conducted in vasculitis. They included patients that were both new and relapsing, and LOVAS only included newly diagnosed patients. There was a mix of PR3 MPO positivity in Pexivast, whereas the majority of patients in LOVAS were MPO positive, and this has to do with the geographic region that patients were recruited from in Asian countries. Predominantly the ANCA is MPO. And in Pexivast, the majority of patients ended up receiving cyclophosphamide. This is because Pexivast started recruiting in 2013 when rituximab wasn't used very much. And of course, we know that half of the patients also received plasma exchange. And in LOVAS, everyone received rituximab and nobody received any methylprednisolone pulses, apparently. In LOVAS, they actually excluded people with pulmonary hemorrhage and excluded people with severe kidney dysfunction or who were on dialysis. And in terms of the two different types of steroid tapering, LOVAS, their two groups were either 1 milligram per kilogram or 0.5 milligram per kilogram to start. So if you were a 70 kilo male, you would start off taking only 35 milligrams a day of prednisone. And Pexivast, everybody started at a high dose of 75 milligrams, but very quickly by the third week, the reduced dose group had dropped to half of what the standard group was taking, and then that continued over time. And in terms of the outcomes, both LOVAS and Pexivast treatment arms, the lower dose treatment arms showed reduced serious infections. And LOVAS actually also demonstrated an overall reduced serious adverse events. So, and neither study showed any difference in end-stage kidney disease or death. Or in LOVAS, they looked at these two outcomes separately in terms of these two steroid tapering arms. So this is pretty compelling that we reduce infections when we give people less steroids, and that probably contributes to reduced adverse events. So these two studies were included in a systematic review and meta-analysis that was published, and really this systematic review just included these two trials. And when they used the grade methodology, they actually found when they combined the studies that the reduced dose steroid taper might reduce death with low certainty and probably reduces serious infections at 1 year with moderate certainty. So it turns out, though, that in the real world, people are tapered much, much more slowly than even the high dose taper arm of Pexivast. So I studied consecutive patients with ANCA-associated vasculitis who were seen in the vasculitis clinic in Toronto. And based on their induction start date, and these were all patients referred by outside rheumatologists or nephrologists mostly, based on their induction start date, determined what their target dose of steroids would have been according to the RAVE tapering protocol. So that's kind of the more conservative tapering in red. And we arbitrarily defined delayed tapering as when the patient was taking more than 10 milligrams above their target dose. And we found that the mean dose of all ANCA-associated vasculitis patients at 12 weeks was 28 milligrams a day, compared to their target, which would be 15 milligrams per day. And when we looked at patients who had quote unquote appropriate tapering, so within the 10 milligrams of what their target dose would be, versus people who had delayed tapering, which is when they were on much higher than 10 milligrams above the target dose, we didn't actually see any differences in baseline disease activity scores, at the time of diagnosis. Of course, those were calculated retrospectively, but we did see that delayed tapering was observed more frequently in patients who'd received pulse steroids and patients who were taking cyclophosphamide. And also those patients tended to have worse kidney function. So probably what's going on is that people are still afraid to taper prednisone in patients who have severe disease, although there may be people that just love to give steroids. And so patients who receive pulses are also more likely to receive slower steroid tapers. still a little bit unclear, but we feel that we felt that when we made the CANVAS recommendations that at minimum, we should just recommend that a steroid tapering protocol or regimen schedule be followed in some capacity, and that we can safely say that you can initiate steroid tapering within 2 weeks of receiving induction therapy in patients with severe GPA or MPA. And then we also recommended that the reduced dose steroid tapering protocol, that being from Pexivas, but this could also apply to Lovas, could be considered in patients who received cyclophosphamide or rituximab induction therapy, which will reduce serious infection risk. But the main point is to follow some form of a tapering regimen. And so in the appendix to the recommendations, we provide the two different tapering protocols. If you followed the RAVE protocol, you'd still give a person less cumulative steroids than what seems to be happening in the real world right now. And both of these tapering regimens can also be found on the CANVAS website. So what about no steroids? Increasingly, there's different trials. There's usually small, looking to see whether we can even further reduce the amount of steroid that someone receives during induction. There's some studies that have tried combining rituximab and cyclophosphamide from Europe. There is a study from the group that did the RAVE trial looking at an ultra short course of steroids of only 8 weeks. They did have more relapses than the historical RAVE cohort, but it wasn't a head-to-head study. But the idea of completely getting rid of steroids altogether happened after there was an initial trial of this drug avacopan, which is this oral C5a receptor antagonist, called the CLEAR trial, published in 2017. And this was a phase 2 study that gave investigators the idea that we might be able to give avacopan completely instead of giving steroids altogether. So the way they designed this study was it was a placebo-controlled randomized trial where patients had to be sick enough to be getting either rituximab or cyclophosphamide for induction. And patients who received cyclophosphamide received azathioprine for maintenance, whereas patients who received rituximab for induction weren't given anything for maintenance, which is one of the criticisms of this study. And you either got avacopan or placebo avacopan, and then the group with placebo avacopan got prednisone, while the avacopan group got placebo prednisone. So they got 0 steroids from the time they were started in the study. And there was a several week period before trial entry where probably both groups got some steroid and even pulse steroids, but they weren't allowed to be included in the trial if they'd received more than 3 grams of pulse steroids. And so, like I said, this drug isn't approved yet by Health Canada, but it was approved in the US this past fall. You can see that while the prednisone was stopped at about the 6-month mark, avacopan was actually continued for the whole year. So this was another criticism of this study. This is just showing you that this little Pac-Man is kind of what we would think about avacopan blocking the C5a receptor, blocking the complement pathway that activates neutrophils and causes this, probably triggers the whole cascade that leads to vasculitis. And they found in this study that avacopan was non-inferior to steroids for induction at 6 months, with no difference in overall serious adverse events, but less steroid toxicity, which is what we'd expect. And avacopan was also superior to the steroid group in terms of relapses at 12 months. And you might argue, well, that's not fair because people received avacopan for the whole 12 months, but stopped steroids at 6 months. But you can see that the curves actually seem to separate even before prednisone and placebo prednisone were stopped here. I think that cost effectiveness will be a major determinant in the decision-making in Canada as to whether this drug and who is going to be able to access this drug in Canada. Will it be only given to people with the most severe vasculitis, or will it be given to people with the highest risk of steroid toxicity, or will it just be given to people who can pay for it? I'm not sure. So in summary, so far, infections during induction are linked to cumulative steroid use. And if you start tapering at the 1 to 2 week mark and stick to a schedule, you'll be better off than the average person receiving treatment for ANCA-associated vasculitis, at least in the GTA. And steroid-sparing drug regimens are definitely the future. So I'm going to speak now about plasma exchange. And plasma exchange was hypothesized to be effectively therapeutic in ANCA vasculitis because the ANCA are felt to be pathogenic, although we're not entirely clear how that happens yet. But the thought was that removing them from the blood would stop the organ damage more quickly. And so PEXIVAS, like I mentioned, the second branch of the PEXIVAS study was to randomize patients to either receive plasma exchange or no plasma exchange. And they looked at the primary outcome, which was the composite of end-stage kidney disease or death. And they found that there was no difference in this outcome between groups who received and did not receive plasma exchange. And when they designed this study, they had the assumption that patients who were protected from end-stage kidney disease would also be protected from death, which is why they considered it to be a composite endpoint. What this group did after PEXIVAS was published is they updated a meta-analysis that they had initially done in 2011, this time incorporating data from the prior 9 RCTs and the data from PEXIVAS. And this time, instead of just looking at the overall outcome at long-term follow-up, which in PEXIVAS was at 3 years, they looked at the 12-month follow-up as well as the long-term follow-up. And again, they confirmed that plasma exchange doesn't modify the risk of death in the short or long term, but does in fact reduce the risk of end-stage kidney disease at 1 year. While this effect attenuates over time, but serious infections are actually increased with plasma exchange. And this effect actually persists in the long term. So now we have a bit of a predicament because you may argue that reducing dialysis at 1 year is really important, but we also don't want to give people serious infections because we know that that's another cause of death, a competing cause of death. And I should say most of these estimates have moderate certainty, but the end-stage kidney disease and serious infections at long-term follow-up have low certainty with the estimates. So in fact, what they figured out is that the amount that plasma exchange helps you depends on your baseline risk of requiring dialysis at 1 year at the time of the treatment decision. So first, what the group did is they pooled data from 7 RCTs, and they found that just serum creatinine at the time of treatment decision could give you a pretty good prediction of who is going to develop end-stage kidney disease at 1 year. So that if your baseline serum creatinine was more than 500, you had more than 25% chance of developing end-stage kidney disease at 1 year. Whereas if it was less than 200, your baseline risk was very low, less than 2.5%. Of course, we know that kidney biopsies can provide lots of information on renal prognosis as well, and that's a limitation of this approach, but they had pretty good test characteristics for this prediction with the data that they had. And so basically they found that the greater risk of you requiring dialysis, the greater benefit you would derive from plasma exchange, such that the number need to treat is only 7 when you're considering someone with a creatinine of 500 at the time of treatment decision. Whereas if you look at someone with a creatinine of less than 200, the number need to treat for them would be 1,000. So it definitely not be worth it. However, the number need to harm with a serious infection also needs to be considered. And even if you take someone in the lowest risk category of developing a serious infection without plasma exchange, the number need to harm is still 37. But if you take kind of a more average risk of serious infection, which in PEXIVAS was 30%, we're talking about patients with severe ANCA-associated vasculitis, the number need to harm is 12. We don't really know yet how to predict someone's baseline infection risk. There's no risk calculator yet, or a very validated one yet, but we could probably make an estimated guess based on someone's age and comorbidities, for example. So the question everyone has is, why does plasma exchange increase serious infection risk? And this is not really clear. In other diseases that use plasma exchange, it hasn't been demonstrated in the past. So it might be that plasma exchange removes some protective immune factors that are needed to fight infection. But this hasn't been demonstrated, to my knowledge, in any other conditions. And they looked at the type of infections that were being caused, and it wasn't just things like Lyme sepsis, for example. So they need to drill down a little bit more to understand this infection risk, because it was a big surprise. So in the BMJ rapid recommendations that were published based on this meta-analysis, which have now been published in 2022, and so have been published after the ACR, the American College of Rheumatology recommendations, and after the CAN-VASC, the Canadian recommendations. They do recommend, based on the number needed to treat and the number needed to harm, that plasma exchange should be offered to those with moderate to high serum creatinine. So basically anyone with a creatinine above 300. And this is assuming the patient's preference would be to have a serious infection in exchange of not needing dialysis in the next year, which may not be the case. And also we have to tell patients that in the long term, they may not be protected from dialysis, but they, I guess, would stave it off for longer, which could be better for their overall health theoretically. But this is why tools to help patient decision-making are desperately needed, because I would have a really hard time communicating these different risks to patients. And the other thing that's important to mention about this meta-analysis and this recommendations is that patients just with pulmonary hemorrhage without kidney disease, the meta-analysis does not support the use of plasma exchange, because there doesn't seem to be any benefit. So this will be the last section, which is a short section on antibiotic prophylaxis. So here's the next audience poll. How long should we continue antibiotic prophylaxis in ANCA-associated vasculitis induction? Should you do until prednisone is less than 20 milligrams per day? Should we continue it until cyclophosphamide has finished? Remember, that could go up to 6 months, but usually up to 3 months. Should we continue it until induction therapy is finished, but longer if they're receiving rituximab maintenance? Or is the answer, I don't routinely use antibiotic prophylaxis? Okay, so I'll end the poll and I'll share the results. So most of you would stop antibiotic prophylaxis when prednisone is less than 20 milligrams a day. And then it's probably divided with some rheumatologists in the audience who continue it for a bit longer. So the question we are really asking is, what are we using antibiotic prophylaxis for? Is it just for PJP, or could it be for other infectious complications? So actually back in 1996, this trial, I think from the Netherlands, but now the second author here is a rheumatologist in Edmonton. This trial was to assess the efficacy of Septra full dose as a disease modifying agent in GPA to prevent relapses. But what they found as a secondary outcome is that patients had significantly fewer respiratory and non-respiratory infections in the treatment group. And that seems pretty obvious because they were receiving full dose antibiotics that are pretty broad spectrum. And there hasn't really been much study on this question until a couple of decades later, when researchers were trying to determine just general risk factors for severe infection during rituximab treatment in ANCA-associated vasculitis, and found that long-term trimethoprim sulfamethoxazole, and this was mostly at prophylactic doses, but in some cases at the full dose, with a mean duration of 15 months, was associated with a reduced hazard of serious infections when adjusting for other factors. And then a third study, which was published last year in Japan, also found a very similar effect of Septra on the risk of all-cause severe infections during induction treatment. And the majority of patients just actually received steroids alone because that's their practice in parts of Japan. And 27% of them received cyclophosphamide, very few of them received rituximab or other treatments. But you can see that the effect estimate is very similar to the prior study. And they use propensity score matching as well in this study, as opposed to adjusting in the Cox regression as they did in the other study. And you can see that there's the time to serious infection is significantly longer in people who received prophylaxis. And in this group, because there was a high rate of intolerance to Septra, they actually tested 2 doses of prophylaxis. So one was 3 times a week equivalent of double strength, and one was even half of that. And they found that you could get away with actually a lower dose, at least in this population. So Septra has been recommended for some time for the prevention of PJP, but now it's also very likely that this prophylaxis also reduces all-cause infections. And even though those were both retrospective studies and are prone to different forms of bias, the fact that they both give similar estimates, I think, is reassuring. And we have the randomized trial from 1996 showing something similar as well. So this is important because when you're telling patients they have to take another drug, you can tell them that it could protect them from all-cause infections, as opposed to just a rare type of pneumonia. And in the Canvas recommendations, we say that anyone receiving cyclophosphamide or rituximab should receive infection prophylaxis based on what was done in the RAVE trial, which is they continued for 3 months after the last cyclophosphamide dose and for 6 months after the last rituximab dose. What this implies, though, is that if your patient is on rituximab maintenance, like every 6 months, maybe they should be continuing Septra long-term indefinitely. And probably that's not entirely true, especially as some patients continue rituximab up to 10 years, for example. But there may be somewhere in the middle that we should be aiming for. Of course, we have to consider that Septra carries a 20% rate of up to 20% discontinuation rate due to adverse events, with the number needed to harm in one study from 2007 being 32. And you can't forget to adjust Septra in renal failure and look out for different drug reactions, including cytopenias after initiation. And probably it's actually more likely that it's the Septra causing this than the cyclophosphamide in some cases. And then there's a question of what to do about people who have a Septra allergy. Certainly, dapsone and atovaquone have not been shown to reduce all-cause infections, and so those should only be used as PGP prophylaxis. But like I said, we still don't really have data much beyond 12 months to know if antibiotics should be continued indefinitely. Probably not. For example, if you're continuing rituximab for years and years, which we don't even know if we need to be doing that. In summary, I've reviewed the current treatment algorithm that we use for severe GPA or MPA, and reviewed the current evidence behind the following measures, which are some of the gray areas of ANCA vasculitis treatment, those of steroid tapering, pulses, plasma exchange, and antibiotic prophylaxis. And now we can go to questions.
Thank you very, very much, Arielle, for this wonderful, extensive review of the literature in this very, very, very interesting field. I'm just going to open the floor for questions. We have a question from Dr. Parimo. Thanks for the excellent talk. Very practical. Can you comment on obtaining ANCA at the MUHC? She has found that the results can be delayed for weeks and a quick result would have guided therapy. Can you talk about this? How do you get this this at the MUHC?
Hold on a second. I'm going to try to bring up something. I don't know if it'll work though. Okay, well, that's loading. I will start to answer that question, which is that we're actively trying to find a solution to that. As some of you might know, ANA and ENA and anti-DNA testing is now delayed between 2 to 3 months to get the results, whether you're an inpatient or an outpatient at MUHC. ANCA, it can be obtained a little bit more rapidly, but it still takes a long time. Supposedly, you're able to call the lab or call the medical biochemist on call now to get a stat results, but there's still a little bit of miscommunication between the people actually executing that and the people that say that it will happen. The current plan is that anyone who's in the ICU will have any of those tests I just mentioned done as soon as possible. And in some cases, we have succeeded in getting the ANCA to be done almost immediately, within a few days. But sometimes that requires currently escalation all the way to the medical biochemist on call. Let me just share my screen again. Can you see this? So unlike, you can see or no see?
Yes, we can.
Okay, so unlike ANAs that took a dramatic turn for being extremely delayed starting in March of 2021, and I still have yet to figure out why that is, ANCAs are have been maybe stable for the last several years, maybe with more variability more recently, but it's still kind of unacceptably, like the median turnaround time is about 10 days. So that might be fine for someone you're working up for interstitial lung disease as an outpatient, but it's probably not fine anytime you have someone with acute kidney injury and hematuria proteinuria in the hospital. And so we have a committee now that is trying to work on this, but so far, until we have a solution that we will obviously disseminate throughout the Department of Medicine, I'd recommend calling the medical biochemist on call. Well, first starting with the core lab, and then if they aren't helpful, then trying the medical biochemist on call.
Perfect, thanks for that. We only have a couple of minutes left, so just quickly, Dr. Azuelos is asking, with respect to steroids concerning allowing potential ongoing organ damage versus infectious risk, can you monitor disease activity, decide on steroid tapering schedule? Is there a role for monitoring ANCA levels, etc.?
Okay. Well, I think the trials that we have kind of are reassuring that we won't be promoting ongoing organ damage even if we taper the steroids. So that is good. But obviously, I normally do blood work at least once a month, if not every 2 weeks, if they're on cyclophosphamide during induction. And if you see that the creatinine is going up or the proteinuria or the hematuria is increasing, maybe that would cause you to taper a more slowly. Certainly, if someone has recurrent hemoptysis, you might have to re-increase the steroids. In the short term, I don't think ANCA is helpful in like those first 3 months during induction. Many people believe that ANCA monitoring in the long term can be somewhat helpful, because if it goes from negative to positive, it does increase the future hazard of having a relapse, although not everybody who becomes negative to positive will 100% develop a relapse. But from time to time, maybe twice a year, even when someone's in remission, some people do monitor ANCA testing for that reason. So I would say the best thing to do is monitor the patient clinically, and certainly there's times when the Pexivast taper anecdotally has not worked. And anecdotally, from what I've heard, at least in Canada, among my colleagues, it's been in patients with pulmonary hemorrhage. But the sub-analyses of Pexivas don't really support that observation. So we probably need more real world data. But if you're uncomfortable with Pexivas, the other option is just sticking to another tapering schedule that's more conservative.
Fantastic. So Arielle, I'm going to have to close the session because it's 1 o'clock. So thank you very much for the wonderful lecture. Really, really interesting. And congratulations on all the work you're doing in this field. And I'm going to ask you if you can maybe just look at the questions in the chat and perhaps continue to answer the questions that are there that we haven't been able to answer yet. Thank you everyone for joining us, and have a wonderful afternoon. Thank you, Arielle. Bye-bye.